Welcome all of you, and those of you who are just joining, welcome to the PALTMed-Colorado monthly meeting. My name is Sing Pallant. I'm the president of this organization. And just a couple of announcements before I hand over moderation of today's meeting to Val. PALTMed-Colorado, of course, stands for Post-Acute Long-Term Care Medical Association. It is the new name for CMDA. And so we will, between now and next April, just call ourselves by both names to try to ease ourselves into the new one. But go ahead and start using the new name whenever you can. And under this heading, because we're now the PALTMed-Colorado, the PALTMed-Colorado annual conference will be here in Denver in April. We have a date. It's April 24th, 2026. So mark that on your calendars. We'll get that sent out and get some registration set up online for you to all come and invite your friends. The PALTMed National Organization, we are the state chapter of PALTMed. The national organization is having their national meeting on March 26th to 28th. That's going to be in Anaheim, California. I know several of us are going, and we hope to have a Colorado-specific reception for those of you who do go. So please join us for that as well. All right, well, Dr. Val Shade is going to be moderating today's meeting. So, Val, go ahead.
Awesome. Well, thanks for joining, everybody. This is great. I am here today. I'm presenting our speakers who are awesome. Thank you so much, everybody, for contributing to this. I really appreciate it. One of them that is here today just agreed to this not but a couple weeks ago. Thank you so much. And that's Dr. Jody Ryan. He's with Wellpower. And he is a Canadian who recently received his U.S. citizenship. And he otherwise went to school up in Canada in Toronto and fellowship of the Royal College of Physicians and Surgeons. And he was telling me that he enjoys hiking and especially cold night hikes. Oh my goodness. I said, watch out for our mountain lions around here. So, Dr. Ryan, take it away.
Hi, thank you for the introduction. And let me make sure that I can share this appropriately. So I want to make sure that I understood the guidance for this talk. Here, one second. Let me share. Do you see the screen, the slide?
Yes.
You do? Okay, thank you.
Yep.
Because it's I don't necessarily see it right in front of me, and so I may turn to look at each slide. So bear with me, because I've got 3 screens in front of me. But I was asked to come and do a talk on antipsychotics, and I think actually I'm a pretty good person to do that, because I graduated residency in 1999 at the University of Toronto, worked for a couple of years before actually coming to Colorado for vacation, and was hired at the what was then the Mental Health Center of Denver, which is now Wellpower. And I've really actually, my career there's been a lot of change, and especially in the antipsychotic world. And so I think that I can speak to that. And I do want to say from the beginning, I do not have any relationships to disclose with any pharmaceutical companies. This is me speaking on my own from Wellpower. So I wanted to look at how antipsychotics are classified, because I think that that's a really important position to start with, and then to look at how they work, like their mechanism of action, because I think that how they work and which receptors they affect can really help you understand side effects or adverse events. Adverse events when you're reading the PI, but side effects in our world. And to take a deeper dive looking at long-term concerns, because I think that I may share a few surprises with people as I go along. So, these meds, well, let me start with the talk is about antipsychotics, but we don't really think of them as antipsychotics anymore because these drugs do a lot of things. They do more than treat psychosis. And so we refer to them as, um, um, oh my gosh, I have a cold, by the way, and so I'm a bit spacey this morning. We refer to them as, oh my gosh, I can't, the psycho. Oh my, I've had a cold and this is my first day back, so bear with me. But really, they do broader things, as you know, as treat bipolar depression. They treat mania, and and so calling them an antipsychotic is antiquated, and the word will come back to me as soon as my mind allows it to. But really, I wanted to start with typical psychotics, and really they are the first generation antipsychotics that came to market up until about 1989. They work primarily by blocking D2 receptors, and pardon me by using this expression, but really they take a shotgun approach. So they have a spray. These drugs affect D2 receptors. They block them and block them really well, but they also sprayed and affected a number of other receptors, which caused differences between those drugs. And then around 1989, and that the reason behind this date will become clear as I go through this, came the onset of atypical antipsychotics. And that started with clozaril, and then risperidone, and then olanzapine, and then Seroquel, Abilify, etc. And by the way, I will be referring to medications by not only their brand, but their generic names. And what made these drugs unique is they blocked not only D2 receptors, but also serotonin 5-HT2A receptors, which modulated dopamine release. And then finally, we've got the newer antipsychotics, and this is like the Goldilocks effect, where they're partial D2 agonists, but really they block and then they tickle the receptor to release dopamine. So they again modulate the flow of dopamine really specifically at the D2 receptor. And then you've got others that have come to market that don't even affect D2. They affect glutamate or they affect serotonin. And so there's a really unique drugs that I don't have as much experience on, but I think that they're really clever mechanisms of action. And, I will say that this talk is focused around schizophrenia. And, our understanding of schizophrenia is only as good as our tools that we have, so that the drugs that we have to treat schizophrenia. And so that's something that I always take into consideration when I'm thinking about the illness, thinking about the person, and like what's important in terms of helping this person in recovery. So, mechanism of action. I've talked a bit about that. I'm going to start with this slide is important because there's 4 dopamine pathways in the brain. There's the mesolimbic, so midbrain, the ventral tegmental area, to the limbic system, which is the middle of the brain. You've got the nucleus accumbens and all those important midbrain structures. You've got the nigrostriatal pathway, and this is behind the basically how these drugs basically mimic Parkinson's disease. You've got the mesocortical, midbrain to the cortex, the front of the brain, which is important in cognition. And then finally, you've got the tuboinfundibular pathway, which is responsible for releasing prolactin, and that's particularly important with risperidone and Invega. So be mindful of these 4 pathways as we go. And I will say that we were really concerned about the mesolimbic pathway with typicals. We became concerned with mesocortical and the tuboinfundibular as well as nigrostriatal pathway with atypical antipsychotics. And then now looking at those other modalities like glutamate and serotonin, as well as partial modulation of dopamine, like I mentioned. What became really popular in the early 2000s was what was called the fast dissociation from the D2 receptor. So we had typicals come online, and then we had atypicals, and people were like, why are these drugs so unique? And well, there was a lot of thinking about how long you stay on the D2 receptor. So a drug like Haldol stays on the D2 receptor for about 2 or even 4 days. So it's a really tight binder. And incidentally, Abilify is also a tight binder. Whereas a drug like Seroquel will stay on the D2 receptor for about 15 milliseconds. So it's not long. I think olanzapine might be 20 minutes on the D2 receptor. And so what we realized with the newer drugs is that how long you stay on the receptor is also important, and and may also explain why these drugs don't have as many movement disorders compared to typicals. And it also changed our thinking about the disease, right? It's not about blocking dopamine, like shutting it down, because we need dopamine in order to enjoy novelty. We need dopamine if we're playing a video game. We need dopamine in order to engage with others. And so really it's not about blocking it, but it's about tickling the receptor, interrupting the flow. And this theory was really important in our thinking about how the atypicals are different from the typicals. So I'm going to talk about the typicals first. And the typicals, as I mentioned, block D2, tight blockers, clamp everything down. And as you know, that results in EPS symptoms, right? You've got like the Parkinsonism, you've got the cogwheel rigidity, where when you move the person's arm, you can feel it holding back, and it really is like a cogwheel. You've got the tremor, and you've got the mask-like facey shuffling gait in people. And long term, you've got the risks of tardive dyskinesia, that chorioathetoid movements that can develop over time. And incidentally, the risk of TD is highest in women and women with movement disorders. So I'm always mindful of that. And also mindful of like typicals are notorious for developing TD. And so that's a risk that I always review with people that I think are important for long-term monitoring as well. The other thing that's important to review is sedation. Some of these drugs can be very sedating, and some of these drugs have been removed from the market because of their impact on potassium channels in the heart, which led to torsade de pointe and cardiac arrest in some individuals. One drug in particular that some may be familiar with is Mellaril. We no longer are able to write Mellaril because of its risks with cardiac functioning and sudden death. So this slide I like, and I encourage everybody to get familiar with some of these meds. And if you're not, right, pick a med that you're interested in getting familiar with, like Haldol, for instance. It's a high potency drug, meaning you don't need to give a lot in order for it to have the effect that you want. So, I've started people on 1 milligram or even 2 milligrams. Don't go, excuse me, very high. I know that, in the early 80s, there was this high thinking that if you wrote high doses of Haldol, I mean like 50 milligrams per day on people, that was effective. It was called rapid neurolepticalization. And we know that, no, that's not good for somebody. Really, you want to be gentle on people's receptors. And why I like Haldol, I will say, is that it's quite effective when somebody has comorbid meth use disorder. You want something that will stick on the D2 receptor and not be displaced by methamphetamines. And so I've really found Haldol to be effective when somebody is using comorbid meth, just like I find actually Abilify to be helpful, because Abilify is also a tight binder and can prevent that receptor from being susceptible to the effects of meth. Prolixin is another medication that's up there as a high potency, low dose. And so, 5 milligrams BID or 10 milligrams BID for a higher dose. I've used Pimozide in my career. I've even used Mellaril in my career until it was pulled from the market. And thiothixine or Navain is another medication that I've used. The medium potency drugs like perfenazine, 8 milligrams is equivalent to about 2 milligrams of Haldol. And I've used perfenazine frequently in my career, and there was a study that came out around the mid to late 2000s, which showed that perfenazine was just as effective as many of the atypical antipsychotics, what I thought was quite interesting. And then loxapine. Think of loxapine like Clozaril without the agranulocytosis attached to it. Loxapine is sedating, which can be helpful in some cases. and is calming, and you don't have to worry about the ANC monitoring. And then finally, you've got low potency antipsychotics, and you've got chlorpromazine identified there. It's more sedating, and I included a PDF that compares the prescribing of these doses. And so with typicals, we always looked at what's the equivalency in 100 milligrams of chlorpromazine. And so that was the gold standard in looking at these meds to basically get a sense of like, how do I convert somebody from, let's say, chlorpromazine to Haldol, or Haldol to perfenazine? Now we've got like ChatGPT. I frequently use ChatGPT and ask it, say, hey, you're a prescriber and you've got a psychiatric patient. All right, this person is on this dose of drug. How many milligrams should I consider for perfenazine per se, or for Abilify per se? And I really find it to be helpful, and then I don't have to refer to the charts. But I do encourage you to look at them because it's really helpful to familiarize yourself with these meds and get a sense of like, what's a high dose, right, in Haldol? What's a low dose in perfenazine? And so you can over time, you can gauge someone's response based on the dose. So the with atypical antipsychotics, like I mentioned, D2 blockade was there. It didn't stay on the D2 receptor like typicals, but it also had a modulator, and that was the 5-HT2A antagonism receptor. And what this did was it released dopamine into the synapse in the mesocortical, which was important for cognition, in the tubo-unfundibular pathway, which was important for prolactin, and then finally the nigrostriatal pathway, which was important for EPS. Okay, so it was these drugs were thought to be novel because they blocked dopamine, didn't completely block it per se, but modulated the flow in other pathways that we were beginning to recognize were important in schizophrenia. So less side effects, and so that people were able to focus and to think and be able to take care of themselves. And it really changed our understanding of recovery, right? It's not just doing one thing, but drugs had to do a lot more. And so our expectation of these medications increased over time. And by the way, or actually I should make reference. Now here's the Achilles heel of these drugs. Metabolic side effects. Like this was a surprise actually. And I remember in the late 1990s prescribing olanzapine, and a patient who had psychosis came back to me and she goes, you know what? I'm eating 2 bowls of cereal every night. And we laughed about that because we didn't realize the impact, right? The impact of weight gain, the impact of on cholesterol, on blood sugar. And that only came to light like in the early 2000 to late 2000. And so, I put on there early predictor of weight gain is greater than 2 kilograms of weight at week 3 with olanzapine. That is somebody you switch. And there's also a marker too with triglycerides, and I wasn't able to find it for this talk, but if you see a triglyceride increase at 6 weeks, and I think it might be above, I can find it and get back to all of you, but that's also an important marker to pay attention to with olanzapine, and consider switching if you've got a profound increase in triglycerides. But really, we started to pay attention to the metabolics of our folks. We started to talk to people about the importance of exercise. We started to actually do waist measurements on people as well, because out of all of these things, right, waist measurement, your girth actually is the strongest predictor of metabolic syndrome with these medications. So here's a list of all of the atypicals. We've got clozapine in 1980. 1989, that feels like a long last century, right? Of course. But clozapine was released in the 1970s, and I believe in Finland they had a number of deaths connected to agranulocytosis. It was pulled from the market. Then there were studies done in the mid-1980s showing that it was really efficacious, especially in people who've been tried and failed other medications. And so it was reintroduced with the REMS monitoring, or the risk mitigation strategies, which we know the The REM system has been dissolved. We still monitor people's ANC, but we don't have to register people and follow people. And so that's new. But we had clozapine came out in 1989, risperidone in 1993. And when we used risperidone, we thought it was like the cat's meow, right? Like this was a great drug, but really it was a drug that spanned atypicals and typicals. And so we would dose it up to 12 milligrams a day, which is quite high because I don't go beyond 4 to 6 milligrams with risperidone anymore because it doesn't have a linear dose response relationship. You only get so much bang for your buck with risperidone. And so I've stuck with under 6 milligrams, and clearly we saw increases in EPS when you went over 6 milligrams and went to the 12 milligram dose. So quetiapine or Seroquel was next in 1997. 600 or 800 milligrams was indicated for schizophrenia, and I've seen this go up to even 1800 milligrams in some people. And I have to say that, out of all of these meds, it is I mentioned that it dissociates rapidly from the D2 receptor. And any drug where you identify, oh, this might be a strength, it's also its greatest liability. And I don't think that I've found that Seroquel is not an effective or predictable antipsychotic. And I think it's because it doesn't stay on that D2 receptor as long. You want to interrupt, but maybe you want to stick around a bit longer on that D2 to more profoundly interrupt the flow of dopamine in order to get that antipsychotic effect. But this was a unique drug where, we saw it actually be beneficial in other ways, right? We saw it be beneficial in depression, bipolar depression, and we even saw it be effective in depression as an adjunct, right? And so you saw these meds go from being antipsychotics to being mood stabilizers, and being used in a variety of ways. Then Geodon came to the market, and Geodon was like the Ryan Leaf of antipsychotics. It looked good on paper, but didn't translate well into the field. And so really we had trouble, like people had to have 1,200 calories in order to absorb Geodon, right, for it to be effective. And I never got it to work with my folks who were outpatients and who had complex needs because people weren't able to do the timing right with taking Geodon with meals and getting that full absorption for the drug to be effective. The other thing is Geodon prolongs the QTC. And so it was the first atypical that really brought attention to the risks of QT prolongation and got us to look at all of this class again after doing it with typicals, but doing it with atypicals again. And so Geodon really caught my attention. And made me pay attention to where I prescribed it, getting EKGs on people, and paying attention to other meds that people were taking that could prolong the QTC. Then we had Abilify, and I'm going to hold off on Abilify and switch to Invega. Invega, so it's the cousin of risperidone. It largely avoids the liver. That's its strength. And so, if people had liver issues, then I would go to Invega. Because because I didn't have to worry about interactions as much. Saffrus or acenapine, I actually tried taking Saffrus once because I was curious about what this drug would feel like. I have to say that that was a little bit of a mistake. I probably should have done it maybe on a Friday afternoon as opposed to a Tuesday afternoon. It really zonked me. I felt really tired and it really took the wind out of my sails, I would say. And so Saffrus is really effective, not only as an antipsychotic, but in bipolar mania. I do see its strength there. And you put it under the tongue. It was the first sublingual antipsychotic. And really, when they changed the flavor to black cherry, that really helped because it was really intolerable without the black cherry flavoring. Fanapt or iloperidone. There's a lot of promise with this. Think of this as Clozaril without the agranulocytosis. You can have somnolence at the beginning. You can have dizziness and orthostatic issues for the first 2 weeks. You start low, go slow. This actually is the one drug here where you don't see any EPS. So that's the unique strength of iloperidone. It's not used that often, and I have to say that I always give consideration to this because you don't see any EPS with this. Then Latuda came to market. Great drug. Again, you had to be mindful of taking it with some food, not a lot of food. 300 or 350 calories. Again, we found that 120 or even 160 milligrams was really helpful for psychosis in schizophrenia and then in bipolar and for bipolar depression. And then finally, Vraylar. And why I like Vraylar, Vraylar is a pill, a shot that's in a pill. So the half-life of Vraylar, or cariprazine, and its active metabolite is 2 weeks. So when I start this with people, I have them take it Monday, Wednesday, and Friday, 1.5 milligrams. I start low, go slow, because I'm worried about akathisia, which you can sometimes see with this drug. But really, it's because the half-life is so long. Anybody who's non-compliant or misses taking their meds here and there, I don't worry about that with Vraylar because, again, the long half-life. It's like the Prozac of the antipsychotic world. So those are the atypicals, and I wanted to go on to the newer ones, and I saved Abilify because Abilify is really the third generation because you've got that D2 agonist, but really it's an antagonist agonist. And so the thinking with Abilify and with Rexulti is that it's a Goldilocks effect that you're just going to hit that sweet spot. And unfortunately, it's like anything else, right? These drugs work well in some people, but not in all people. And it's a trial and error process. And we learned that the Goldilocks effect, like it didn't work predictably in everyone, right? It did in many people, but not in everybody. And then you still had issues with EPS, akathisia, and the claim to fame with Abilify and more with Abilify is that it's such a strong binder that if I'm on Invega and I've got hyperprolactinemia, you give a bit of Abilify, it helps modulate the dopamine acetylcholine balance in the tuboinfundibular pathway, and it causes the release of prolactin, and so it addresses that side effect. You've also got a few others, Caplida and then Cobempi, which you've probably seen the commercials for them. And I will say that any of the newer ones, I think are helpful to try on somebody who unfortunately has experienced a first break. Because I think that this is helpful for somebody who's new and has not tried any of the antipsychotics. Because what I find is that as people have had undergone a number of trials, right, they become more resistant to treatment. And if somebody has been ill for, let's say, 20 years and are in their 50s or 60s, I really have to go back to the typicals in order to get a good antipsychotic result. The side effects. So EPS I've talked about, and we typically use anticholinergic agents like benztropine, Artane, which is trihexyphenidyl. We are really trying to be careful with these agents, right? Because this leads to cognitive impairment and there's a risk of dementia with these drugs, right? And so I really pay attention to using anticholinergics. I don't write high doses. Amantadine, which is an antiviral agent, it's pro-dopaminergic. It's sometimes used. I've seen people get more psychotic with this, but I've tried it in people, right? Just to see if this offers some relief with people when they've got EPS issues. And then Benadryl. I try and avoid Benadryl, again, because of the anticholinergic effects. And so, be mindful of buying over-the-counter Tylenol, PM, and agents like that. Like we're exposed to Benadryl all over the place. And again, I'm mindful of that anticholinergic effect and the link with dementia over time. Metabolic effects. Well, we've tried to intervene in many ways. And I will say that there's a study with olanzapine, and this was in China, where they used naltrexone, an opioid antagonist, and people did not gain weight. And so this is where the Lybalvi comes from, olanzapine from plus samidorphan, which is an opioid antagonist. This is where this drug comes from. And a cheaper way is just give people naltrexone. If you don't see anything in 2 or 3 weeks' time, I've gotten rid of the drug. You usually see an impact on someone's appetite at the beginning, and if you don't, I've tried other things. But I wanted to
Ryan,
mention this. Yeah.
It's 12:30, so
Oh,
we will need to move on to Lauren's
oh,
presentation. If you want to just give us
yeah.
a little wrap up. Thanks.
Yeah, you know what? So
This is
here's the
great.
last slide. Here's the last slide that I want to pay attention to. So there was this Finnish study that followed people from 1996 to 2006. And what it looked at was all-cause mortality, and mortality related to suicide, mortality related to cardiovascular risks with antipsychotics. And so really it's what they found was giving an antipsychotic, regardless of the drug, keeps people living longer with schizophrenia. And when they looked at the drug Clozaril, it did best despite all its side effects, right? Metabolic risks, risks of seizures, right? Dose response, 200 milligrams, you've got a 2% risk of seizures, etc., and risk of agranulocytosis. People live longer with Clozaril. And Clozaril has a unique indication of the prevention of suicide in the context of schizophrenia. So, even though we're focused on side effects, adverse events, I just want to make it clear, writing an antipsychotic for people will help them live longer. So let me end on that point because I think that that's really important to emphasize when we look at risk benefit with these meds and with people's lives.
And thank you so much, Dr. Ryan. That was very informative. I appreciate you. And
Okay.
everyone will have access to those slides. So we'll make sure that you guys have an opportunity to be able to look at those maybe with a little more time behind you.
Okay. And thank you. And thanks for the opportunity. I appreciate this.
Yeah, this was really great. I appreciate you. And again, Dr. Ryan is in our buildings with Wellpower, and we appreciate having him. Yeah.
Thank you. Thanks. Bye.
Okay, so right now it is time for our next speaker, who is Lauren. Lauren is she is a PharmD, and she is going to be talking today about antibiotic stewardship. She's got this great little antibiogram.
Thank you so much, Val. Hopefully everyone can hear me. Thank you, Dr. Ryan. That was really interesting. I love going back to the pharmacology, so thank you for bringing that. As Val mentioned, my name is Lauren Biehle. I am the antimicrobial stewardship lead at CDPHE. So if I haven't met you yet, please feel free to reach out if we can help you with anything regarding antibiotic stewardship. I am so honored to be able to present in front of this group and talk about a project that we recently completed, which is summarizing antibiotic resistance across the state. So we have now both hospital and nursing home antibiograms available publicly on our website. And I'll have a QR code for that. I'll also put it in the chat towards the end. And today I'm going to be focusing on the nursing home antibiogram, but if you have questions about any of them, feel free to let me know. So today my objectives are to describe the role of antibiograms in clinical practice, guideline development, and surveillance, describe the development of the antibiogram that we created of data submitted by nursing homes across Colorado, and illustrate the application of antibiograms in the nursing home setting. In addition to the antibiogram itself, we created a one-page quick guide for how to implement an antibiogram in your nursing home stewardship program. So I'll be talking about that as well. I wanted to begin just by framing it with a couple of sample cases. As many of you are aware of antibiograms and their use, a lot of us can refer to the first case in which a female presents to the emergency department from the nursing home with symptoms of a UTI. As empiric therapy, a provider can rely on antibiogram to determine what may be the most susceptible bacteria and then choose their antibiotic from there. I also want you to encourage you to think about the public health role of antibiograms and why we're interested in them, which is, for example, if one of our epidemiologists at the health department notices an increased number of carbapenem-resistant isolates, there may be clusters, there may be ways that we can track this. And so an antibiogram, by summarizing those resistance patterns over time, allows us to get an idea of where things may be having transmission and where we can contain things. As all of you know, there are many considerations for antibiotic selection. I'm not going to spend too much time on this slide, but I think it's also always helpful to think about where we're getting our information. So things like our infection factors, like colonization first infection, things like our potential pathogens based on the site of infections and the patient's history of resistant organisms. The patient's factors themselves, are they immunocompromised? What's their healthcare access? the drug characteristics. So what route are you using? How frequent is the dosing? What collateral damage could the patient experience based on using things that could cause more resistance down the line? And then all of that going into our clinical trials and guidelines that guide our practice. So because we're talking about antibiograms, I'm going to be focusing on this section here, which is the potential pathogens. So the suspected pathogen, the patient's history of resistant organisms, but then also local resistance patterns. And so we're trying to see across the state as more local than, say, federal, what do our antibiotic resistance patterns look like? This is a hospital-based slide, but I think it's helpful. When the CDC, they do a point prevalence survey around every 5-ish years. And in this one, what they found with hospitals was that more than half of antibiotic prescribing prevents in hospitals was not consistent with recommended practices. And one of the things that they recommended was things like antibiograms to optimize that antibiotic selection. So as far as antibiograms, it's just an analysis and presentation of cumulative susceptibility data over time. There is a standardized methodology for putting it together, which is what we followed, and that's based on the Clinical Laboratory Standards Institute M39 resource. So it's a summary of this data over a set time, typically a year. Although I'll say, if you're, say, a nursing home that may not have as many isolates, that can be combined over multiple years. So in this case, it is 1 year, but sometimes, again, you may see them as multiple years or multiple regions. And so it's typically organized in this way, with the pathogen on the first column, the number of isolates tested, and then the percent S, or the susceptibility to each of the antibiotics, on the following columns. I'm going to go into a little bit more detail, but for us in antimicrobial stewardship, antibiograms are very relevant. We use them for action. So things like you can use your susceptibility testing to decide what may be your go-to for treating a UTI or treating a pneumonia empirically. You can use it to guide those stewardship actions. When it comes to tracking, you are tracking the resistance pattern with the antibiogram. So that's inherent to tracking as part of stewardship. And then with reporting, we do encourage, if you have an antibiogram at your site, to be reporting that back to your prescribers and staff, as well as in settings like QAPI. To go into a little bit more detail, again, these are just examples of the clinical application of antibiograms. I'll also be talking about the public health aspect of antibiograms. So for action, again, providing that guidance before cultures return, identifying potential targets of intervention. So if you're noticing, our E. coli susceptibility is decreasing substantially to fluoroquinolones or to Bactrim or things like that, you may be able to use those resistance patterns to identify some targets of quality improvement. For tracking, it is tracking that microbiology data and then identifying any local trends or emerging resistance concerns over time. So again, if you're noticing we're using a lot of this antibiotic and it's affecting our susceptibility data, that may be something to intervene on. And then finally, like I mentioned, reporting. So reporting at the facility level with prescribers and staff, reporting out to QAPI. And then of course, we at Public Health love for you to report if you're resistant isolates to us as well. From the public health side, we use it for quite a few things. So for surveillance, again, tracking those resistance trends of pathogens, identifying emerging resistance or potential clusters. We do set up our quality improvement and our goals around certain antibiotic resistance trends, whether it's carbapenemases or other things like that. We also communicate this aggregate data not only to facilities, but to organizations like CDC for them to track things on a multi-state or federal level. And then one of the things I really love that I know is a challenge in nursing homes is that I think antibiograms also do some level setting for laboratory standardization. So, you need to know what breakpoints are people using and what kind of data is being submitted, and it needs to be in a way that can be analyzed. So I think antibiograms also support that standardization of data. I wanted to narrow down to nursing homes specifically. So we know that nursing homes, residents of nursing homes are often at risk of increased MDROs compared to hospitals. We also know that you have to rely on broad spectrum antibiotics empirically until laboratory results return. And one of the things I find interesting is that if you are working in a hospital setting, you may think, oh, well, the nursing home that's nearby could use our antibiogram as a substitute. And that is, better than not having one. But at the same time, we know that hospital resistance data is not equivalent to that long-term care resistance data. So if you can get data from your own facility, that's going to be better. However, there are a number of challenges to creating antibiograms in long-term care, and this is something that we've heard about anytime we work with facilities on creating these. So a lack of a sufficient number of clinical isolates. You need to have 30 isolates per organism per CLSI. And so often for nursing homes, this may end up looking like you have just E. coli on your antibiogram or something like that, whatever you see quite a bit of. In addition, whereas hospitals can just ask their microlab to print out all of their results, that data accessibility may be a challenge between whichever microbiology lab you're using and then the facility. As you'll see in this antibiogram that I'm going to be sharing, urine cultures are by far the most common. And so, for example, if you are going off of this data driven by urine cultures to treat things like wounds or bacteremia, they may, those types of infections may be underrepresented. And then finally, we know asymptomatic bacteria is the biggest driver of antibiotic use in the long-term care setting. And so if there are a lot of patients being tested for urinary tract infections that may not be clinically relevant, that could also skew your microbiology results. So I have a QR code if that's easier for you, and I'll also put the link in the chat. But I wanted to share the nursing home antibiogram that we put together. So in this antibiogram is based on a single microbiology lab in Colorado, and it's a report of 2023 antibiotic resistance data. The goal of this antibiogram was to provide a publicly available tool for stewardship, increase knowledge of antibiotic resistance, inform allocation of resources to improve antibiotic use, and inform population level stewardship strategy. So very much recognizing, I'll go over all of the limitations of this antibiogram, and also, recognizing that this would not be the clinical tool that you would use day to day in your own facility, but more so a summary of looking at this aggregate data. So we reviewed that 2023 data submitted to a single microlab. We only included organisms with 30 or more isolates, so we won't have everything on there. I'll go over the organisms that we did include. Because of the way the data was sent to us, we did have to exclude polymicrobial isolates. So this is only going to be if the resident strictly grew E. coli or strictly grew Klebsiella. Those are the only ones that we could include. Another thing I wanted to note is that we divide up the facility addresses by region, and the majority were in the Denver metro at 53%, followed by the Southeast at 30%, and the Northeast at 17%. Unfortunately, this laboratory does not serve the Western Slope. And so for that reason, unfortunately, there will not be local data to the Western Slope. So only those other 3 regions are represented. 95% of our isolates were urine cultures. So this is definitely more of a urinary antibiogram. I've listed the other sources that we did use. So those include wound, blood, and then a couple of stool and throat cultures as well. In addition to the requirement of 30 isolates, CLSI also requires or recommends deduplication. So the reason for that is, let's say, Mrs. Jones was tested 15 times in a year for her urine. We wouldn't include all 15 because in that way it could potentially skew the results. So instead, we do the first isolate of each organism per resident per year. So we went through and cleaned up the data to only have those isolates represented, which also then cuts down on the number of isolates that you have within the antibiogram as well. So we produced these antibiograms for gram-positive and gram-negative bacteria. Gram-positive, we were able to include Enterococcus, both E. faecalis and E. faecium, as well as Staph aureus. And then for our gram-negatives, we included E. cloacae complex, E. coli, Klebsiella, Proteus, and Pseudomonas. And so I'll share both of these in the upcoming slides. To calculate the percent susceptible, we just simply looked at the pooled number of isolates considered susceptible as their final result by the microbiology lab over the number of isolates tested. So it's a straight percentage of %S over the total. We did not include intermediate. I did want to, again, address the limitations because, like many antibiograms, there are limitations. So the vast majority were urine cultures, 95%. We did have to exclude polymicrobial isolates based on the way the data was given to us, and so that did limit the number of isolates available for analysis. Facilities in the Western Slope do not submit data to this laboratory, so they unfortunately are not represented here. There may be some potential for data suppression. That's always a possibility with antibiograms, and that would be specific to the individual lab. And then, of course, noting that not all nursing homes in Colorado submit data to this lab. So I am going to post this first one here. This is for gram-positive bacteria. And I'm going to check the chat really quick just to give everybody a chance to look at this. Thanks, Val. Okay, perfect. All right, so just to orient you to this table, the first column is the gram-positive organisms. Second column is the number of isolates tested per antibiotic. We include a median because there is a range based on the different antibiotics. And then to the right are the antibiotics based on their abbreviation with the full name in the footnote. So I'm just going to go over a couple of the highlights of this one, as well as for the gram negatives. So we have Enterococcus and Staph aureus. The Staph aureus are then broken down into MRSA and MSSA. So when it comes to Staph aureus, they are 100% vancomycin susceptible and 100% linezolid susceptible. Our clindamycin susceptibility is only 69%, so it's pretty low. And our Bactrim susceptibility is at 95% or above for all of our Staph aureus. The other thing just to note is doxycycline was not tested, but tetracycline was. And so for tetracycline anyway, there's about 75% susceptibility to Staph aureus, and that is slightly lower with MRSA. I know we're getting close on time, and I know Jenny has fabulous updates, so I don't want to dig into her time. But this is our gram-negative antibiogram. And so, again, we have those organisms there in that first column. I wanted to mention a couple of highlights here. And like I said, I'll put the antibiogram in the chat if you want to take a look at this a little bit later as well. For E. coli, which I know is something we're all concerned with, and by far the most common submitted was 875 isolates. Our fluoroquinolones are hanging right around 74% as far as susceptibility to those. Bactrim is around 77%. And nitrofurantoin is still very high at 95% for these E. coli isolates. I will move down to Pseudomonas just because this is the one we've received the most questions about. So we had 179 isolates to review for Pseudomonas on average. Our fluoroquinolones were about 80 to 90%, but our imipenem was only 42% susceptible. The majority of that is intermediate, so it's not all just straight resistance, but just wanted to mention that we are seeing more and more resistance for carbapenems and Pseudomonas. So I wanted to mention that as well. Any questions before I go on to the summary slides?
These were, Lauren, specimens submitted from nursing homes. It doesn't
Correct.
when the last time that person was in the hospital or something.
Exactly. Yep. So this is a laboratory that serves nursing homes, and so it came from directly from the facility. And predominantly urine, again. All right, I will stick around for questions, but just wanted to summarize as well. We do have an antibiogram quick guide that we created. So this is a one-pager. If you want to have an antibiogram in your nursing home or help with interpretation of a nursing home and how it applies to your program, we have that one-pager available on our website. And so I can put that link in the chat as well. And so in summary, our antibiograms summarize our antimicrobial susceptibility or resistance data, which inform our work in stewardship. They also inform clinical decisions. We aggregated resistance data from nursing homes for a publicly available tool for stewardship. And long-term care facilities can utilize the antibiogram quick guide for developing and interpreting antibiograms. The other thing I was just going to throw out is that I will send this to Sing, but please look out for, we're going to be creating a long-term care community of practice in antimicrobial stewardship. So this will be a quarterly call for anyone involved in antimicrobial stewardship, prescribers, pharmacists, IPs, nursing staff, anyone involved is welcome to join. And we're going to have specific topics, the first one being on UTIs and asymptomatic bacteriuria, and just have a forum available for discussion that'll meet each quarter. The first meeting we have tentatively set for December 12th, so trying to get that done before 2026. And with that, I'll stick around with any questions and put the link in the chat, but thank you so much.
Awesome. Thank you so much, Lauren. I so appreciate that. That was really, really informative. And I think that we can all use some takeaways from that. And I look forward to being involved with your group there later.
That would
And
be great.
last but not least, I have Jenny Albertson. She's Director of Quality and Regulatory Affairs with, she is with CHCA. And she is going to give us some association updates.
All right. Good afternoon, everybody. Thanks for having me again. I'm going to zip through this 30 seconds per slide. Losses in the CDC are starting to impact us, and I wanted to be sure we are aware of what elements of the CDC are laid off, terminated as roles, etc. They had mass layoffs during the Doge cycle, and then there was a whole lot of political sort of infighting that resulted in resignations. They had a shooting at the CDC that killed a police officer. Essentially, it's been traumatic at the CDC. And because of that, there have actually been shutdowns of whole entire divisions, departments within the CDC. And we do rely on them for disease information heavily nationally. And this is going to divert some pressure onto other organizations and state level public health. So the MMWR team, which puts out our epidemic intelligence reports, that is no longer in existence. We don't get those disease reports anymore. There are no disease detectives who are tracking threats. There is no bioterrorism division anymore. They eliminated all of the ethics, well, not all of the ethics staff, some of the staff from the ethics division. Congressional outreach is no longer happening, where Congress people have an arm of people notifying them of public health risks. Health statistics is no longer present. Nutrition surveys, all of their human resources, and I already talked about weaponized pathogens and biodefense. 1 in 3 CDC employees has lost their job in the past few months, and there will be a cut of half again as much with the implementation of the current budget as it is framed if they do not adjust it before approving it. So there is an effort to fill the gap of information. New England Journal of Medicine evidence publication is going to kind of try to jump in where the MMWR, the Morbidity Mortality Weekly Report, has left a vacancy. So local and state health departments will be able to look to this. You all will be able to look to this. And it hopefully will be an uncensored, unbiased environment for us to receive actual scientific reporting. CDC scientists may have information to share, but will not have liberty to share it through this avenue. They have only the ability to transmit information to the public via the CDC. So if it's not a governmentally sanctioned communication, they cannot contribute their research. So take this as it is. And I have a few things in the chat here. Let's see. Okay. This is all about the previous presentation. Thank you. Okay. Just want to make sure I'm not missing anything. CMS did recently release an updated physician fee schedule rule, and this is sort of going to impact you all, but sort of not. So one thing that became clear as they were talking through their rule is that they seem to believe that since most physicians that are working in hospitals are now considered employed by the hospital, they think the same model is functioning in a skilled nursing environment, which may be the case if you're a medical director via contract, but it certainly is not a normal practice for skilled nursing environments to employ physicians directly. So some of this will be massaged when they kind of understand that a little better. Our national partners are trying to make this very clear to them, but they have decided there would be an overall percentage of increase for Medicare Part B services. That'll be particularly for outpatient therapies and a few others. There will be a liberalized view of telehealth provisions for physician consultation via telehealth. So we had heard that as of October 1st, telehealth was essentially eliminated except for end-stage renal disease, behavioral health, and substance use. Those things were made permanent, but they have just recently added in this final rule a permanent rule that we do not have restrictions on frequency or subsequent nursing facility visits via telehealth, or if we are unable to reach our patients, rural or otherwise. So there's no restriction on where they are. There is a press release out there. I've given you all the links on this so that if you want to look in greater detail about Part B billing, you can see it. Okay, respiratory pathogen guidance has been updated through CDPHE. These are the primary takeaways. Most of the change is in assisted living. There's one guidance for nursing facilities and intermediate care, and there's one guidance for assisted living. They basically made assisted living like our community environments. The main thing is if you've had someone on work restriction in an assisted living setting, they're just supposed to mask for 5 days after they're without a fever and symptoms are improving, just like if you were in the community. We still have to abide by CDC guidance for restrictions for respiratory pathogens in the nursing facility environment. That's the bottom line. Links to the detail are here in the header, and you can go to both the nursing facility one and the AL one if it's of interest. Under flu and RSV, they did have more latitude to update, and so they removed some mistaken contact precautions for infection control for flu and replaced it with droplet and standard. RSV, they talked about the work restriction and the 5 days of masking. So again, trying to align as much as possible so there's not this constant need to reference back to the guidance documents. And they did put in a handy dandy table, and there's a little visual for you. This OIG fall report that just recently came out may have upset a few people. And I just want to make sure to clarify that they actually are referring to some pretty limited data, and it's ignoring some of the very apparent differences between coding in a hospital setting about falls versus coding in a nursing facility setting. So I thought ACA's quotes here that they published were very salient and illuminating. Basically, they're saying it's not reasonable. It's not reasonable for us to expect the two to equate, particularly because when we send someone to a hospital post-fall, we do not always receive back the patient or the information about what the outcome was of that fall. So to say that fall with major injury is underreported in nursing facilities is really not capturing everything. Plus, MDS has very strict guidance and instructions as to how we are to time our capture of data and code it. And that is completely different from how hospital claims are transmitted for reimbursement. It's just apples and oranges. So at any rate, there's a whole gap in between here that didn't get captured in the aggregation of the data. And I hope in the future they do something to try to rectify that. But for now, there's kind of a misinformation out there that makes it look like nursing homes are being somehow nefarious. This is just a heads up to you all. This is not something obviously that you directly would be impacted by, but know that your RNs who are constantly doing humongous med passes could be relieved if they happen to reside in these counties. If the facility wants to put CNA through a med aid training program, they can do med passes under the supervision of a nurse. This is a great program. It's usually about $1,500 per person, but it gets it done, and then they are an additional set of hands. Often I hear really positive things from our patients when we do this because they trust their CNAs to communicate with them about the medications they're receiving. So a new 15-day course is opening up in Denver. We have not had a med aid training in Denver for years. This is the absolute total of med aid trainings statewide that are approved by the Department of Regulatory Agency. So it's pretty limited. This is kind of a fun one for you all, talking about medications and all the polypharmacy risks that we always talk about here. We are now free to use a medication reconciliation toolkit and training modules on ACA's website. So if you're interested in this, tell your folks it's free. Get your ACA login. I can help them do that. And it comes with, slide presentations, handouts. They can use it for their staff. They can bite size it in particular modules. It goes through what is med reconciliation, steps for doing it, roles of the IDT, and regulatory review. And then these are our member opportunities coming up. We did just hold a Director of Nursing Essentials class. So any of the buildings that you cover where the DON is new, they loved being on this training. There were 24 of them. And most of them said, yeah, I was just thrown into this and have no idea what I'm doing. So it was excellent to give them kind of a top to bottom review of all of the things they're required to do for regulatory compliance and survey, and their relationship with the medical director was covered. It was an excellent course. So we have our member update coming up tomorrow. If you want to hear more from me for my 1-hour update, you can also get a recording of that and slides. Our Essentials of Environmental Services is a 3-day course. And then we are doing a bronze quality workshop mid-November before we get into our hiatus for the holidays. Thank you.
Woo! Wow, Jenny, way to go. Yeah. Thanks so much. Thanks for giving us that update. I didn't see any specific questions in the chat. I don't know if anybody has anything before we sign off here. I know want to be very respectful of your time, and thank everybody for coming. I really appreciate it. This was this was great. This is very chock full of information.
And I know Chad just got back from being off, but usually he gives us an update. Do we want to see if there's any brief update from Chad?
If Chad wants to be put on the spot.
Used to it.
I am. Can you hear me?
Yeah.
Awesome. Yeah, I just wanted to say that I think you've all probably recognized that our engagements with each other have been a little bit different since the government shut down. We've received a good deal of direction from CMS as to what is allowable and what activities we are not legally authorized to perform. I'll just do a quick little nutshell. I think you're going to see us come out to your facilities when we're looking at complaint and fry surveys where there are credible allegations of immediate jeopardy or harm. And this is really the level of engagement that we'll have in terms of processing findings, writing deficiencies, setting out the 2567, the deficiency list, and then any enforcement. All of that stuff will happen at the scope and severity of findings that are harm or higher. We are able to do some revisits by exception, and these are going to be revisits that are going to prevent a possible termination or prevent statutorily mandated denial of payment for new admissions. We've been able to do some state-funded surveys, so licensure surveys, as well as surveys in Medicaid-only facilities. These surveys would be like the annual inspection. So pretty much that's kind of the level that we're operating on. IDR is something that we're also have shelved essentially until the shutdown is over, with perhaps an exception for situations where immediate adverse action may be taken against a facility. Examples of that would be termination of provider agreement, and if that were to occur during the shutdown. So again, we're operating on essentially complaints and revisits having to do with scopes and severity of harm or higher when the allegations are of actual resident harm. Hopefully we can get ourselves through this sooner than later, and we'll be able to resume business as usual. I will have to say, when that time comes, we'll have about 45 days to pull all of our shelved information, so citations that we've gone out and maybe we didn't cite harm, but there are citations. We'll have a shortened period of time to get all of that stuff back in order, and hopefully be fast on our track to catch up the recertification surveys, particularly in the 89 out of 211 facilities that are presently overdue.
Thank you. Hang in there.
Wow. No shortage of work.
Certainly.
Yeah. Yeah. Well, thanks very much, everybody. I really appreciate you coming and listening to all of our wonderful presenters. I think we did a great job. Singh, did you have any other announcements?